Good afternoon. My name is Leanne Briggs, and I will be your moderator today. I'd like to welcome all of you who are participating in our Caregiver Support Group Live and to our viewers on YouTube. I'd like to introduce Gary Powell, the Executive Director of the Caregiver Foundation, who will introduce our guest speaker for today. Gary?
Thank you, Leanne. Welcome, everyone. I hope your week has started off a little less busy than mine, but I hope it's a great week for you. We are really pleased and honored to have Dr. Suzuka back with us. Thank you for your presentation last year and this year for the update. We're looking forward to all your wisdom. Dr. Suzuka has been practicing medicine in the state of Hawaii since 1985, I believe. He went to University of Hawaii and then to Yale University. He's been a prominent figure in the medical community here in Hawaii for a very long time, and practicing on the North Shore as a family physician, he has really been a blessing to all the people who've come into his clinic. The clinic is now part of the Queen's Healthcare Centers in both Haleiwa and Mililani. Dr. Suzuka, I think you're still visiting the university job some and doing some lecturing or professoring. I know that I've had people going to school there. I look forward to being able to study under you. So that's great. And we are so grateful that you're here with us. I could read through your CV here and we could spend the rest of the day doing that. Let's just suffice it to say that Dr. Suzuka has been engaged in family medicine in the islands here in so many different areas, from the Boy Scouts to plantation work, to helping train new physicians in our community. And we are really terrific. You're a terrific guy and we appreciate you being here very much. And I'm going to just turn it over to you and sit back and learn.
Okay, so I'm going to share my screen and then we'll get going. Someone sent me some questions. I think we'll cover most of the questions in the talk, but there are some that that will come back to later on. Okay, so yeah, as Leanne mentioned, last year's talk was on February 16th, so one day from today. Okay, so we're gonna go through this. Oops, let's see. How come it's not? Oh, there we go. I had to press harder. I'm not pressing hard enough. Okay, so this is the first report from World Health Organization dated January 5th, 2020. And you can see in the highlight in the yellow, at that time they found no evidence of significant human-to-human transition. So that has changed altogether since this first report from the World Health Organization. Shortly after, we had reports from many medical journals reporting this new novel coronavirus that started in China in 2019. Or did it really start from China? We still don't know for sure. There are spot reports from other places that the pandemic may have started even earlier than that. So there's one in Italy where they were doing a lung cancer trial and found that 14.2% of the people, the blood samples, had evidence of SARS-CoV-2 in the blood samples, even back from September 2019. And then December 1st was patient 0 in Wuhan. And even though they linked it to the Huanan seafood market, that first person, that patient 0, actually had no contact with the Huanan seafood wholesale market. Okay, and then by January 5th, as we mentioned, the WHO published information regarding the disease and said there's no evidence for human-to-human transmission. Flash forward then quickly in January through March, it becomes a pandemic. And as of March 11, 2020, the World Health Organization then declares COVID a global pandemic. On March 13th, President Trump declares a state of emergency And actually on March 16th, believe it or not, about 2 months after China released the genetic sequence for COVID, on March 16th, 2020, Jennifer Haller received the first COVID vaccine in Seattle, Washington, at Kaiser Permanente in Seattle, Washington. This is a kind of a summary of COVID in Hawaii, going all the way back from April 19th, 2020. Yeah, at that time you might remember that we thought, or not we, but there were some people that thought that COVID would be gone by Easter. And we, as we now know, that did not happen. But boy, that's the good old day. You know, you talk about the good old days. The good old days was back there when you can see the cases were hardly anything. And it doesn't start to hit Hawaii until August of 2020. And then we, you know, we go through the holidays, we have a few blips. And then, and remember that the vaccination started in December of 2020. So we thought back then that the pandemic was over. We'd be getting vaccinations, everything would be fine. And then we go, and we're doing pretty good in 2021. People are starting to get vaccinated. Vaccination rates are probably in this, maybe in Hawaii it was in the 60%, in other places it's still down in the 30%. And then in June of 2021, the Center for Disease Control says that if you've had both vaccines, you don't have to wear a mask indoors. And then comes the 4th of July, and we can see that spike that occurs from the 4th of July, and that's the Delta spike, right? And then here, September 5th, I don't know if any of you remember, but on September 6th, Hawaii almost ran out of oxygen. So we almost did not have oxygen in the state. So Delta starts to subside, we're doing good. And then come November, so remember beginning of November was when Omicron was discovered, reported in South Africa. And then we see the Omicron spike that we're just getting over now. So you can see historically, and this is when we can really say, oh my goodness, this was the good old days. Who thought that June 2020 was the good old days? But that was the good old days. So this is sort of Hawaii's picture of what's happened in Hawaii with COVID. Now, when you look, this is actually from the Hawaii data. And this is, actually, I just did this today. So this is the distribution of COVID in Hawaii by race. And as you can see, the ethnicity that's hit the hardest is the Filipino population, followed by Pacific Islander and Japanese, and then Native Hawaiian. So those are the 4 biggest hit demographics. If you look at age, so there was a question on how the elderly have done, and you can see that most of the cases are in people over 60 years old. Males are disproportionately affected over females. And then if you look at underlying conditions, people who have at least one underlying condition greatly exceeds the mortality in COVID. There was a question on the difference between epidemic, pandemic, and endemic. So epidemic is when there's widespread community outbreak over a particular time. Pandemic just means that instead of a community, now it's over the whole country or the world, but it's still limited to a particular time. So that was in in March, March 11th, when the CDC declared COVID a pandemic. It had affected the whole world. And now COVID is probably endemic. In other words, there's not limited by time anymore. It's going to be here to stay. Example, and that could be in a particular area. For example, malaria is endemic in Africa, but it's not endemic in the United States. COVID will probably be endemic all over the world. It already is endemic. Okay, some things that we've learned from the talk since the talk last year. One is that you can get Omicron even if you had a booster. So you do get better protection. So if you had 2 shots, you have 30% protection from Omicron. If you've had the booster, you've had 3 shots, then you get 70% protection. That still means that 30% of us will get Omicron even if we've had the booster. So this is very different. Remember, back with Delta, if you had 2 shots, it was 90 something percent effective in preventing you from getting sick. But with Omicron, you still have a 30% chance you could get sick even if you had the booster. The other thing about Omicron is you can get infected again. So in South Africa, 14% of the
I
people who got
unmuted, but I'm just getting a buzz.
okay, yeah, in South Africa, 14% of people got Omicron a second time. Um, and so that goes. We're gonna be talking later on about what's in the future. But the funny thing is,
Muting.
it's the same thing as in 1918 with the flu pandemic. Masks work. Face shields and masks work even better. The biggest risk is from your family and friends. So in the healthcare setting, like with Queens, the risk of getting COVID in a healthcare setting is 1%. So people coming to see us, the risk is very low. The risk is biggest when you're looking at families. So your family is more likely to give you COVID than your doctor is. Okay, now here's some questions. The reason I came up with these scenarios is everybody can get tests now. You can get four tests for free. And Biden's ruling says that you can get 8 tests from your that should be covered by your insurance company. Now, the tricky part is I'm not sure it's clear how you get those 8 tests covered, and every insurance company is different. So you probably want to call your insurance company and say, "Hey, how can I get my 8 tests for free?" Some people you go to a retail store like Long's or Walgreens. Other people you would probably buy the tests if you can find them, and then mail in the receipt to your insurance company. But it's not clear exactly how you would get your tests covered, but you can get 8 tests covered for free. Okay, so the big thing is that now that you can get the tests, what do you do with the information? And there was a very interesting study in JAMA Internal Medicine just within the last month, and they had 3 scenarios. One scenario is they gave people questions like I'm going to give you, and they had one group had the package insert from the test. So they had the actual package insert that was approved by the FDA. The second group was given no information, and the third group was given some simpler to understand information. The interesting thing on that study was that the worst scenario was when you read the instructions given to you in the package instead of the antigen test. So 40% of people that read the instructions on the antigen test got the answers wrong. 30% of people who had no information, they had no information by which to go by, 30% got it wrong. And with the simplified test, only 4% got it wrong. So I thought, hey, that's a good reason to kind of go over some of these scenarios and see what people might come up with your answers. Again, this is not graded, so you don't have to worry about this, and we will give the answers on the next slide. So let's say you were traveling with some family members, you went to Las Vegas, and one of the members that you had close contact with, that means within 6 feet for 15 minutes in a 24-hour period, test positive for COVID. They call you when you get home and say, hey, I hate to tell you this, but I had a positive COVID test. So you do a home antigen test because you got some free ones now, and it's negative. You already had your booster, and right now you have no symptoms. What should you do? Okay, and I'll go on to the next slide. According to the CDC, you do not need to do anything. Technically, you've had your booster, your COVID test is negative, you don't need to do anything. Now, you could, actually, all of the answers could be correct. So if you wanted to, you could say, I'm going to just check again. If you want to check, I would check at 5 days, and we'll get into why that's so. If you want to be really certain, let's say that the people that you have contact with, so maybe somebody has cancer and you want to be sure that you don't give it to them. You can certainly, to be safer, you could isolate for 5 days. And if you really wanted to be safe, you could self-isolate for 5 days and recheck a COVID test in 5 days. So all of the answers are correct, but according to the CDC, if you wanted to do the minimum, you could do nothing because you already had your booster and the COVID test was negative. Okay, here's scenario number 2. You were at a Super Bowl party last week, and now you have a runny nose, no fever. Somebody at your party tested positive for COVID this week. You had your booster, and your home antigen test was negative. What should you do? Number 1, you could do nothing because you had your booster and the COVID test is negative. You could recheck the PCR in 5 days. You could self-isolate for 5 days. You could self-isolate and check the antigen test in 5 days. Okay, so the answer is you should self-isolate regardless of the test results because you have symptoms. So you have a runny nose, and if you have symptoms, you have to assume that it is COVID. We'll get to the reason for this in a little while, but if you have symptoms, regardless of what your test shows, you should self-isolate. Now, you could, with the new CDC guidelines, you could come out of self-isolation after 5 days. And if you want to make a little bit more sure, you could check a COVID test in 5 days, but you should self-isolate no matter what for 5 days. Okay, last scenario. You had a Super Bowl party last week. Someone tested positive for COVID this week. You have symptoms and your home COVID test was positive. You do a PCR test at 5 days and it's positive. 10 days, you do another PCR and it's still positive. What should you do? Remain in self-isolation till you have a negative PCR test. Do an antigen test instead. Do nothing, you can be out of isolation. So in this one, you don't have to stay in isolation anymore. You fulfilled your 5 days of isolation. That PCR test could be positive for 90 days. Okay, so you would not want to get another PCR test if you don't have any symptoms. If you wanted to get an antigen test, you could certainly do that. As we'll show you in a little while, the antigen test generally will be negative after 14 days. But the PCR test can be positive for 90 days. So it doesn't make a lot of sense to keep on going back to get another PCR test. You have a bigger chance of getting infected again because you've been out so many times. Okay, so let's look at, this is from the study. This is the simplified instructions that were given in the study to the group that got only 4% wrong. So you can see that if you had COVID symptoms within the last 10 days and you've had close contact, you should assume you have COVID-19 regardless of your test results. Okay, if you've had COVID symptoms within the last 10 days, you still could have COVID, and you should, and I would, if you were my patient and you called me, I would say you should self-isolate for 5 days. And then the third scenario, third column is you've had close contact and you, but your test is negative. These are all negative tests, by the way. You could still have COVID, check with your healthcare provider. Now, on this scenario, if you called me, I would say that if you've been boosted, you don't have symptoms, even if you've had contact, if you want to be super safe, then you can self-isolate. But technically, if you don't have any symptoms, you've been boosted, CDC says that you don't have to self-isolate. And then if you've had no symptoms and you've had a negative, you have not had contact and your test is negative, well, that's an easy one. You don't have to self-isolate. Okay, this is why you assume that your test is positive if you have symptoms, even if the test is negative. So this was a study in Annals of Internal Medicine. And if you look at the conclusion or at the results, that if you do a test on the first day of symptoms, your false negative result is 100%. That means that you have COVID, but your test is negative. On day number 1, it drops to 67%. And the best time to get a test is 3rd day after symptoms, which is about the, with Omicron, that's going to be about the 5th day. But you're going to, and that's going to be 20%. So you still have a 20% false negative rate meaning you have Omicron, but your test is negative. So if you have symptoms, you should assume that you have Omicron, even if your test is negative, and you should self-isolate yourself for 5 days. Okay, and then this is that slide I told you we would go over. So this is the time of exposure on this side, and this is when you don't have any symptoms, and this is the first day of symptoms. Now, the viral antigen test will go up and come down and will be negative probably about day number 10, whereas your PCR test may be positive for 28 days, and in some studies, it's gone out as long as 90 days positive. My son had COVID, and his PCR test was positive for about 28 days. So back then, that was in March of 2020, and nobody knew how long you had to self-isolate. So Stanford, where he's doing his residency, Stanford required that you have a negative test, and he had to stay out for almost 5 weeks until he had a negative test. Okay, so how do you use all those free kits that you get? Okay, so one good way to use it is if you're gonna have a get together. Like, let's say you're gonna have a Super Bowl party. Well, everybody should get vaccinated. They should be boosted, and then to make sure, you might want to have everybody use their free kit to get tested on the day of the party. And if somebody is positive, they should not come. Okay, so same thing. If you're gonna have a wedding or you're gonna have some kind of event, then you might want everybody to make use of the free kit, and if they're positive, they stay home. Another way to use the antigen test is that if you wanted to make sure that you are negative, and you can be go back into into activity, you should still wear your mask, by the way, but then you could use your free test on the 5th day and make sure that that you're negative. Now, the CDC shortened the from 10 days to 5 days for 2 reasons. One is because with Omicron, people tend to get infected early and they shed the virus shorter. But the thing that concerned a lot of health professionals is that 10 to 15% of cases still occur after the 5th day. So the safest thing would be to wait the 10 days, and then you don't have to worry about that. But the reason that CDC said it, one is, when Walensky said, well, 85 to 90% occur before the 5th day. And I'm going like, hey, that's still 10 to 15% that occur after the 5th day. But part of it was, remember back then, we had day. Healthcare workers were being out of action. In fact, at the peak of Omicron, Queens had 843 workers that were out. Not necessarily sick, but they could have been exposed. So shortening the isolation from 10 to 5 days means that airplanes can fly and that healthcare workers can return to work sooner. Now, the role of the PCR test is that's the best test to rule out COVID. Remember, there's still a false negative rate, although some people say that they don't agree with the Annals of Internal Medicine article. And if you're going to get the PCR, you can do it on the 1st day, but the best time to get it is the 3rd to 5th day of symptoms. That's the lowest false negative rate. Okay, here's a different topic altogether. This did not exist last year. So we now have medications that can be used for people who get COVID and are not sick enough to be in the hospital. So 2 of them are pills, the Paxlovid and the Molnupiravir. So Paxlovid decreases your risk of being in the hospital by 87%, and Molnupiravir decreases it by about 30 to 50%. So Truvimab is a monoclonal antibody that's been given by infusion, and Remdesivir is a medicine that we still use for hospitalized patients, but it could be given to people that are not sick enough to be in the hospital, and it can reduce the chance that they land up in the hospital. And then just last week, the FDA approved another monoclonal antibody, and they all have impossible names to pronounce. It's been out to recent, so I can't pronounce it, but Bebtelovimab, something like that. And that one's by Lilly, and that one just got approved on the 11th. So that one just got approved recently. Now, with all of these, These are not medicines that you can just go to Long's and get like you get Tamiflu for the flu. The supplies are extremely limited, and there is a tier system. And the way that the state of Hawaii has decided you're going to get this is you have to be screened, and then if you pass the screening, then you get an appointment. So you could either, probably the best way is to contact your primary care doctor and tell them if you have COVID, if you tested positive for COVID, and if they should be able to go through a risk score with you, and if you meet the criteria, then they can get you into the either the HPH or the Queens system for that. If people want to call Queens directly, they can call the Queens COVID hotline at 691-2619. Okay, but these are medicines that can be used to prevent you from getting into the hospital. And when I say limited, like we had in the state of Hawaii, we had 40 doses of Sotrovimab. And we had, I think, 250 doses of Paxlovid. So not a whole lot. Okay, and then this is another medicine, Evusheld, and that's for people that are at high risk before they get COVID, before they get exposed. And so I did not include risk category 4 because you don't qualify in the state of Hawaii for that. But basically, if people are on chemotherapy, if they're on medicines to suppress their immune system, if they have cancer, if they are on things like cyclophosphamide, azathioprine, if they have lymphomas. So all of the people in these categories can get Evusheld, that's an IV medication, and that protects you for a few months. Again, that's not something that you can just get at your primary care doctor's office. They would have to arrange for you to get it through Queens or HPH. Okay, now we mentioned that masks work, and this is a slide from last year showing that 2 hairstylists with COVID-19 spent 15 minutes with 139 clients. Everybody wore masks. Nobody got infected. So masks work. This is what kind of mask should you use? This is a study from this year, and I'm going to show a slide from last year, but it's pretty much the same. If you notice, the best mask is an N95 respirator, and that gives you the best protection. Interestingly enough, then the next one is surgical mask, 5-layer surgical mask, but a vacuum cleaner bag. Okay, so before Omicron, I had and I still have, I have a cloth mask with a pocket, and I actually will cut up a HEPA filter and put it in that pocket. And so a HEPA vacuum cleaner bag, HEPA filter out 3 micron particles at 90% efficacy. So you can see that a vacuum cleaner bag is almost as good as an N95. Okay, now what about homemade masks? Homemade masks are down here just under 80%, and then it drops after that. So, but you can see that the best is N95, and with Omicron, the CDC has said use the best mask that you can get, and then surgical mask, and then if you have a homemade mask, you might want to see if you can put a pocket so you can put a vacuum cleaner bag in it. This was from Stanford from last year. It kind of gives you the same information where surgical masks were at 90%, vacuum cleaner bags right under that, and then decreasing the efficacy as you go down. And then this is another one. This is from JAMA Internal Medicine. And this one shows the N95 mask. You can see that the amount of infections are way down with N95 and with surgical masks. So surgical masks are the ones that you tie behind our heads, like, you know, in surgery. And here's the procedure mask, which has the ear loops. And that one, as you can see, is only about 50% effective. So these are the 3 different kinds of masks that are in the healthcare field, but definitely N95 is the best one. If you use the procedure type mask, you want to make a knot on it so that the ends are tucked in. The next slide will show you sort of an interesting thing. So this is when people have no mask, and the light blue is when the sort of the source of the infection has a mask, and then the other person does not. And oh, I'm sorry, that's when you have a mask and the person that's sick does not. And then the darker blue is when the patient who's sick has a mask and you don't. And then the dark blue is when both people have masks. So this darker blue, that's kind of what we thought of before COVID. We said masks prevent you from making other people sick. So we used to just have people wear a mask if they were sick, and we didn't have other people wear masks. But we now know that it's best if both people wear a mask. Okay, so it does work if you wear a mask and the sick person doesn't, but it works best if both people wear a mask. So here is the graph for a procedure mask. That's the lowest quality thing. And you can see that if you wear a mask and the source does not, is not that much benefit. If the source wears a mask and you don't have a mask, there's more benefit. If both people wear a mask, that's big benefit. Now, double masking and then the knotted tuck. The knotted tuck does work really well if both people have the knotted tuck. It doesn't work as well if one or the other doesn't have it. And the double masking works also well if both people wear a double mask. So that's just in terms of that knotted tuck that some people may have seen, and in terms of why people may want a double mask. You shouldn't double mask a N95. That actually decreases effectiveness if you double mask an N95. Okay, and here's this one just came out in the last month from the CDC. So this is in indoors, why you should wear a mask indoors. So a cloth mask will only reduce your risk of getting COVID by 56%, a surgical mask by 66%, and an N95 will reduce your risk of getting sick. This is in an indoor setting by 83%. Okay, so what can we do? Another question on the list that was given to me is, what can we do so that we can start to meet again in 2022 when they start to lift regulations? What can we do? Well, social distancing is still good. So if you can social distance, that's important. Wear a mask, and we've gone through the mask data. Wear a face shield. So face shields work in addition to masks. And there was a question whether you can get COVID from eye exposure. Answer is yes. So face shields are a good way to prevent that. When I went to my son's wedding in San Jose over Christmas, I wore a face shield and an N95 mask. And for the first time in my life, I didn't take off my mask or my face shield to drink water or do anything on the whole plane ride. I kept it on the whole time. I did not take off my mask or my N95 mask or my face shield for the whole plane ride. Okay, adequate ventilation. We're going to get to that in a second. Path of ventilation. So it makes a difference where the air is coming in and where the air is going out. And then a MERV 13 filter or better. So MERV stands for the minimum efficacy respiratory value. So they grade filters. We'll show a slide of that later on. Most commercial, most air conditioning is MERV 8 and 9, which doesn't do much. But if we can get better filters, and in fact get a HEPA filter, which is a MERV 17 or better, then that will help prevent infections. And then UV filters. So I think one thing we may learn from COVID is we might in the future build our buildings better, including our schools, including other office buildings, so that we can prevent infections like COVID in the future. Okay. So this is from the one on healthy buildings for schools from the Harvard T.H. Chan School of Public Health. And what they found is that, so the standard is that schools are supposed to have air exchange per hour of about 4. Now, in reality, usually they are only exchanging air about 3 to 4, and that's assuming you have air conditioning. If you just have windows, then it depends on how much the wind is blowing. Okay, but if you can get an air exchange of 6, then that will cut down on infection. So you want air exchange per hour of at least 5, but 6 would be better. And this is that MERV filter thing I talked about. So standard commercial air conditionings will have a MERV filter of about 8 or 9. And remember that COVID is a 0.1 micron particle. So so a MERV 8 or 9 will filter less than 20% of the COVID particles out. If you look at 1 to 3 microns, that's more for like regular bacteria and things. Then you're starting to get a little bit better. And then when you get the bigger particles, that it does help. But if you look, remember we said that you want to have MERV 13 or better. So once you hit MERV 13, then you filter out 79% of the 0.3 to 1 micron particles. And if you get a HEPA filter, you're filtering out 99% of the 0.3 micron particles. So keep in mind that an N95 mask, what that stands for is it filters out 95% of particles that are 2.5 microns. And a MERV 17 filter will filter out 99.97% of 0.3 micron particles. Okay, so that kind of covers the things that are new. I'll stop sharing my screen. Looks like there's a couple questions in the chat too. And then, so I don't know how, let's see. Should we go through the questions?
Yes, doctor. And
Okay.
I can read them out to you.
Okay, sure.
Your presentation was truly enlightening about mask usage. And so, let's see, how do we decide when and where to wear masks?
Okay. I would wear a mask anytime you're going to be indoors, regardless of the mask mandates. I would wear a mask indoors at any time. I would wear a mask outdoors if it's going to be crowded. That Super Bowl really scared me because nobody had any mask on. That was, I'm going, oh, I wonder what's going to happen a week or two from now. Obviously, you cannot wear a mask when you're eating. But when we went to my son's wedding, we would have my mask and I would put it on. And then if I'm going to eat or drink fluids, I take it off. When I eat my bread, I took it off. And then I put it back on while I'm waiting for the main meal. So, and preferably if I have to travel, I would prefer not to go to a restaurant. Now, San Jose and San Francisco is very good because they're just like Hawaii. You got to show your vaccination card and all that. But as we showed you, you can get COVID even if you've been boosted. So that's not 100%. So yeah, I would tend to wear my mask as much as possible. And with Omicron, I'm tending to use either a N95 mask or a mask with with my HEPA vacuum cleaner bag filter. If I go out to Costco, I wear a face shield. And if I'm at church, I wear a face shield. So I wear my mask and a face shield. The face shield thing comes from India. So in India, what they did is they had healthcare workers that went out to the villages, and the villagers had to come out of the house. So it was outside. And at the beginning, everybody was supposed to wear a mask, including the people in the household and the healthcare worker. Obviously, when you have little kids, some kids going to pull down their mask, and not everybody's going to have their mask all the time. But the healthcare workers, and these are not doctors and nurses, they're like community workers. Some of them were still getting sick. And then they started wearing face shields, and then nobody got sick. So the combination of face shield and mask is probably a good thing. So when I go to church or if I go to Costco, I wear a face shield and a mask.
Yeah, more questions about masks. What if you are outdoors, you're walking, do we need to be concerned?
No, if you're outdoors walking, generally not. If you're in a crowded place, like, depending, I would carry my mask with me. And then if I come across like where there's a lot of people and I'm not going to be able to get away, 6 feet away from people, then I would put on my mask at that point. But I would not wear a mask when I'm walking outside.
And another question about masks. When do you think we can do away with masks?
Okay. Yeah. That's one of the things I'm not sure. If you look at Asia, and that's the thing that blows my mind. Okay. is, and right now, New York has done away with their mask mandate. Nevada, including Las Vegas, had done away with their mask mandates. So we have such this thing against masks. It's so hilarious. In the old days, people used to wear a mask, and when they didn't have to, they're called robbers. But now nobody wants to wear a mask. But if you look at Asia, Japan has 125 million people, and South Korea has 51 million people. There was a time when Hawaii's rate was 4,000. We have 1.4 million people, and Korea and Japan had less than us with 125 and 51 million people. South Korea this past weekend had their record high number. It was 13,000. That's 13,000 for 51 million people. Now in Asia, everybody's wearing masks because of pollution. So they wear N95 masks because of pollution, not because of COVID, but that's helped kept them from getting COVID. When you look at the Asian countries, they have been hit nowhere like the European and the United States. We're putting up all these arguments about masks when if you look at other countries, we'd be going like, man, why don't we do what the other countries are doing? So the answer is I'm not sure that we will get past the point where we're going to wear a mask. Now, I think what will happen is that, well, people get sick and tired of wearing a mask. I get sick and tired of wearing a mask. But so people will get lax. We probably will have, like if we don't have a big, I'm worried about Super Bowl, but after Super Bowl, and there's only Easter between now and, then Memorial Day and 4th of July. So I have a feeling we'll do fairly well during that time. And then it's really dependent on what happens. But if there are spikes going on, or if it's indoors, I would probably continue to wear a mask. And hard to tell you when you can stop wearing a mask.
Doctor, did the medical profession see a reduction in flu cases or other?
Yeah. They did. Now, interestingly enough, there's a shift because when people stopped wearing, the thing is people get tired of wearing their mask, and there is some, like if you don't get infected during flu season, you could get infected at other times. So there was actually whooping cough and flu both got shifted a little bit. But, and I didn't see the numbers for this past year, but 2020 to 2021 was like the lowest flu season like in a long time. It was like 14,000 or something people that died from the flu. Is really low.
We have a question about Tonga and their other Pacific Island nations. They have seen a sudden increase of COVID as more people of Tonga, they needed humanitarian aid. Can you explain why this happened?
Because we brought it into them. So that number one, actually, to be honest, I don't know what the immunization rate is in Tonga. But that would have a factor. Seemed like, Africa, their immunization rate was pretty low at the onset of Omicron. I think it was about 36% immunization rate. I don't know what it is for Tonga. But if Tonga had not had cases of COVID prior to the humanitarian relief, and so and remember that 40% of people, that was another question on the thing, 40% of people with COVID are asymptomatic. So if you have people that are asymptomatic, and remember you can have false negative test results too. So if I'm asymptomatic, I actually have COVID, I go to Tonga to help them out, and then I can spread it to them. So it's gonna be a combination, and I don't know what their percent of mask wearing is. So if they never had COVID up until now, it's very likely they don't have a mask mandate. They don't have any of those other things. So I think it's complicated. I don't know for sure for Tonga, but I would imagine those are the factors: immunization rate, mask and social isolation rates. All of those things will have factors involved.
Okay, and then thank you. Going back to the multiple choice questions and the scenarios you had. I don't know about the rest of the group, but those were really hard questions. And so there was a question in the chat. Would it be helpful if the scenarios were more widely publicized? Just giving these little checks to people so that we can kind of navigate our way through these different social settings.
Yeah, the answer is easy. I would say yes. And part of the problem is and we have not had a really good public health rollout. I hope that at the end of this, we look back at COVID and we kind of do a post-mortem, so to speak, on what went well, what went wrong with COVID. And one of the things is going to be the messaging. So like right now, especially when CDC changed their guidelines to 5 days instead of 10 days, it was a mess. And so basically when people need clearance to work, I have to tell them, find out from your employer what's required. So everybody's different. So, and I don't know if it's changed, but for example, the HSTA, the teachers, theirs was 10 days. So they did not change. So if a teacher was sick, they wanted the teacher out for 10 days. DOE was 5 days. DOE was 5 days. Queens is 5 days and then no symptoms, but you have to have a negative PCR. And in essence, you're probably going to land up having a lot more people stay out 10 days, which is fine. I mean, that's the safer thing to do. In reality, you probably don't want your healthcare worker to give you COVID. So I think Queens one is fine, but it's all over the map. And so yes, and there some employers required their employees to get a PCR to return to work, and I would say that's nuts. So I mean, one guy was going to get fired because he kept on getting a positive PCR, and his employer at double talk and says you have to come back to work, but you can't come back without a negative PCR. So I just wrote him after about 20 days. I said he can return to work. He's no longer infectious. But yeah, our standardization of our messaging is horrible in the United States.
And we have a couple of questions about boosters. How long does the third shot, the booster, last? And do you think another booster will be needed?
Okay, great questions. Okay, so what we know is that the booster seemed to last about 3 months. So many of people that have gotten their booster, their immunity is kind of waning down at this time. Okay, then the other question is, will another booster be necessary? Right now, from the data we have from Israel, the answer would be it's not going to help. So Israel is sort of interesting. They have a national health system, and they always have been leading everybody in terms of their COVID vaccination policy by several months. So they immunized everybody, and then they boosted everybody on the first booster. And at the time, the World Health Organization said, okay, you shouldn't do that because many of the countries haven't had their first shot, and you, Israel, you're doing booster shots already. That's not fair. But Israel didn't care, and they just boosted everybody. And that's how we got the data on how important the booster was because of Israel. Now, Israel actually gave everybody a fourth shot. They gave everybody a second booster, and it did not seem to help. So right now, the best data we have is that whether or not a fourth shot helps, we don't know. It's also going to be complicated by the prevalence. So I don't know exactly how prevalent, what's the case positivity rate in Israel at the time they were running their fourth booster shot rate. But so right now, we probably don't need it because Omicron is on a big decline. And it's going to depend what comes up next. And that was another question on the sheet was, will we get another variant? Well, it's already here. So BA2 hit 55% of Denmark and 30% of England. Now, the good thing is for some reason, BA2 does not seem to be hitting the US real hard. So I forgot in which area it was, but the BA2 positivity rate has dropped from 192 to 134 to under 100. So it looks like in at least some areas of the United States, BA2 never made foothold and it's already on the decline. Now, whether or not that happens all over the United States is hard to tell. But BA2, even though it hit Denmark and England really hard, it does not seem to be making a big impact on the US. But there will be more variants. So it's going to be a matter of which one will come out and will it affect us.
We have another question about the asymptomatic people. So is it possible for children to have COVID and they're asymptomatic and then infect the adults in the family? And this would also have some relevance in the educational system as well.
Yes, great question. And the answer to the questions, if I get them all correct, can kids get COVID? Yes. And Omicron was actually worse for the kids than the original and Delta was. So if, I don't know if you remember the slide, but you can always go back and look at the Hawaii data. But there are kids that have died from COVID. And with Omicron, I think at one point, COVID was the 6th leading cause of death for kids. So Omicron does affect kids. Can they spread it to adults even when they're asymptomatic? The answer is yes. So kids can spread it to adults. Does it have ramifications in terms of going forward? The answer is yes. Now, you may understand, because right now, the vaccine is not FDA approved for kids under 5. And the FDA decided to postpone approval of Pfizer's vaccine for kids under 5. So in fact, we were getting ready to deploy Pfizer vaccine for kids under 5. We're kind of in the process of discussing it. So, you know, like I was telling Queens that they should notify all the preschools. And because I'm a medical advisor for my church's preschool, and we've already had a couple cases of COVID. And I know Dr. Amano's kids' preschool also had COVID. So so COVID does hit the preschool, and it's humbug because then the parents have to take off of work. The other kids get affected, and then the kids then infect, you know, teachers and other people. So yes, it is a big problem. And ideally, we would be able to vaccinate all of them also. Right now, Hawaii's vaccination rate for the 5 and up is actually over 85% or something like that. But that's not including the kids under 5. And then there's less people that's, you know, 5 to 18 that are vaccinated. And so they become a reservoir to spread it to vulnerable people. So yes, that is a very important question. Ideally, we'd get everybody vaccinated.
Well, thank you very much, Dr. Suzuka. I think we've gone through all of the questions in the chat. Thank you so much for being so generous with your time. Gary, would you like to say any concluding remarks for Dr. Suzuka? Oh, Gary, you're muted.
How's that? Okay.
Yes. Hi.
Thank you again, Dr. Suzuka. We really appreciate all your knowledge and your wisdom and your willingness to share it with us. And we hope that you'll come back and visit with us, maybe on a topic that isn't COVID. That would be
sure. I know a couple other topics.
Yes. But thank you so much for spending this time with us. We do appreciate it very much.
Okay.
Thank you very much, Doctor. Take care.
Bye.
Goodbye.